Hi, Lindsay. Hi, Lindsay. Can you hear me?
Hi, Judy.
Hi, can you hear me?
Yes, I had turned my video off or my audio off because is her name Sherita?
Yeah.
She called me because she was having issues with her slides. So, and I had something playing on my computer, and then I forgot that I had turned my audio off. So I was like, "What is going?"
Oh, okay. Is she there?
Hello.
Hi. How are
Hi.
you? I can finally
Wonderful.
talk to you.
Your name
Yeah.
just popped up. Hello, I'm giving you a computer hug.
Hi.
So very
Yeah.
nice to see you in person.
I know. It's
And
wonderful. It's wonderful.
Lindsay, is that you?
Yes, that's me.
Is that so nice to put a face to your name?
Yes.
So are you two all set up as far as the tech part is concerned?
I'm just opening the slides and then I'm gonna show you what they look like and make sure it looks okay.
Okay, I'll leave the two of you together.
Okay. It says that they're loading.
There's some pictures in there that might be slowing it down.
Okay. Originally I tried to add it to my Google Drive, but I'm also going to just download it to the computer, but I'm worried that'll change the formatting. We'll see.
And if it does, we'll just work with it. I'm one of the easiest people you will ever meet. I like to think.
They're doing their tech stuff.
Hello.
Okay. Hi.
Oh, yeah, it looks just a little weird, but no worries. That's fine.
Does.
Definitely work with that. I think it's because some of the script some of the fonts we use are ones that we have to download and go through a lot of stuff with. And so I think it makes for a difficult, yeah. And if you want to scroll through a couple, Lindsay, just to be, oh yeah, they look a little different, but that's okay. A few more in and there's some pictures and we'll.
Oh, so these come up by themselves?
Yeah, so when we get to that slide, if you just click through so that they all come up and yep, and that's the last one, that's fine.
Okay.
I didn't realize that it was fading. It must be something in the transition.
Oh, this is going to be so wonderful. I can cry already.
Do you want to, as you go, do you want me to make these appear or?
Yeah, when you bring the slide up, Lindsay, you can bring up the full content on it. Oh, that one's going to look funky. Yeah, because it's lots of rows. I don't know that we can do anything about that one. Or maybe yeah. There you go.
I might need to make the font a little bit smaller so that they all get on there. Oh, self-esteem, that's the last one, right?
I think there are more.
Oh yeah, they are.
I had on the slide, there were 3 columns, but if we can get, whatever you can get is fine. I can talk through some of the other ones. That's good. We'll explain to people we've had some technical difficulties and we'll work with it. And then what I can also do, Lindsay, is leave you with these slides in case some of your other viewers or other folks at the temple would like to see them. Unfortunately, there's not a lot of, I do some notes. I'm looking down like, oh, I cut some of these slides from another presentation. I'm like, oh, there are some notes there. I typically don't do notes, so it's sometimes hard to review them afterwards, but Yeah, it looks like everything else held up fine. Thanks, sweetie. I appreciate you.
Mm.
So this was originally, what were the 3 columns? I might be able to make it happen.
If you can get it to format into 3, that's fine.
It's just 3 parts. It's not.
Yep, it's right. It's just 3 parts. I want to acknowledge Susan and Donna. Hello, hello, hello.
Hi.
Thank you so very much for inviting me.
Thank you for being here.
It is our greatest pleasure. I mean, just seeing this part is exciting and just wonderful.
Well, Judy, you kind of had to know I was going to give you a little more content. I couldn't just do the exact same thing I had done before.
Oh, no, that's fine. That's fine. So right.
I did limit myself in content so that we would have some time to talk afterwards.
Right, but you can take the full hour if you need to. I mean, Susan and I watched you so rushed on that ABC signature event. We felt so sorry for you. I mean, boom, 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 boom. We won't do that tonight, right, Susan?
And really, Miss Phyllis, who was the first speaker, my heart was pounding.
Yeah.
Yeah. I was really, really blessed to do that. Jackie Dozier is one of my most best friends on the planet. Oh. And I always try not to say no to her unless it is just humanly impossible. And so I was really grateful to have that opportunity and to be in that lineup. And they said to me, listen, we're going to put people before you and there will be people after you. So don't use up all the time because we know what happens if you get on a roll. So I said, I'm going to do my best. I'm going to do my absolute best. Only 5 slides, and I promise to move right through them and pass the baton. I promise. So I was really grateful that I was able to deliver on that promise because it was a little bit nerve-wracking.
It was an amazing conference.
Yeah.
Yeah. It really was. ABC and Jerome did a phenomenal job with that. And to be on a virtual platform, but to make it really feel like there was human touch and we were in a shared, really safe space was incredible.
Yeah.
Now,
is this an annual event, Sherita?
So they typically do it as an annual conference, and they moved it this year to the virtual platform because of COVID.
Right.
So, yeah.
Okay.
So how many people tonight are you expecting?
Well, for Dr. Clark, we had 65 people.
Okay.
Which was great. So that's what I'm hoping for. Because of this topic, I sent it to a friend who teaches nursing students at U of R. So I have 4 nursing students who signed up.
Okay.
So
Susan, who's your friend that teaches at U of R?
Her name is Karen Jeanette.
Okay, I haven't met Karen yet. I used to do a presentation for some of their nursing students. And I used to do it annually. And then a few years ago, I think they changed up the curriculum and decided they wanted to do some other things. And so I was, I won't say that I was uninvited. I just wasn't invited to the new curriculum format that they had. But I imagine that they have tons of content to squeeze into a relatively short amount of time. Relatively speaking, so they had to make some choices about who they could have as presenters.
Right. But this is so important, don't you think?
Well, Karen does the clinic. So she's in charge of the nurses' clinic rotations.
Wow. Okay.
Yeah. Yeah. So Sherita, for Temple Sinai is part of RAIN. Do you know you know the organization RAIN?
Mm-hmm.
So when I first heard about Healthy Baby, I sent your information right away to the executive director, because I think, you know, those moms could really benefit from services.
Yeah, one of our programs shared space with the project that RAIN would do every year at Asbury. So we were familiar with their work and had a couple of touches and connections to them. Hello, everyone, and good evening. I see you all joining. Hello, hello, welcome.
Hello. Yes. So Donna's on our committee as well as, and Susan's our director, our coordinator, okay? And Abby is our social action chairperson.
Wave, Abby.
Oh.
Wait, yeah. Thank you, Susan. Oh, and Sharon Silvio, Sharon Wave. Sharon Wave.
Hi, Sherita.
And Sharon's on our committee too.
Nice to meet
Wonderful.
you.
So nice to meet you.
Thank you.
Wow. Now there are so many folks that some of you are off my screen. So I will periodically try to click over so that I can make eye contact and connect as best I can as the crowd grows. How exciting. Lindsay, how's it coming? Is it okay over there? And honestly, if it gets crazy, don't worry about it.
Yeah, I think it's, I'll show you.
Oh, you did incredible work. Okay, you're awesome. Thank you so very much.
Sure.
So everyone, we had last minute technical difficulties that are entirely my fault. I forgot that my laptop that I'm using does not have Microsoft Suite on it, which typically isn't a problem because I'm connecting by VPN to my office. But if I did that tonight, you all would see my empty office desk chair and not my face. So we decided Lindsay's doing wonderful superhero work in the background to fix my slides so that we can use and see them tonight. So I'll be giving her lots of extra appreciation throughout the presentation tonight.
Oh, that's great.
1, 2, 3, 4. Yeah. The work is 17. Oh, good.
Love this screen. This is right there. So did anyone brave the snow and go outside today?
No.
Nope, me neither, Judy. I watched from the window. No, Renee.
No.
You have to go outside if you have a dog.
Oh. And as soon as you said that, Roy's camera came on and his dog walked across the screen in the background. Perfect timing.
Just to prove it.
Just to absolutely prove it. That's right.
It's why we have a cat.
Ah. Awesome.
Yeah, this Chromebook still thinks I'm Val Bogart.
Well, you have to just set it in differently.
Guess so.
You can change it, can't you?
So here come some of our nursing students.
Oh, good.
Hello, hello.
Hi.
Hi. Welcome.
Thank you.
Hi, Maxine.
Hi, Eileen.
Hi, Susan.
This is my childhood friend from first grade, and she worked in public health for decades. She's now retired, but she's very interested in the topic, and she's coming to us from Virginia.
Wow.
Welcome.
Yay.
Welcome.
Welcome.
That's great.
I bet you have less snow than us.
Ice, lots of ice.
And hi,
Yeah,
Beth.
Hi.
So Beth,
Oh, hi, Beth.
very active in RAIN, and she's coming to us from Tucson.
Oh, wow.
Hi, Beth.
Hi, Beth.
Good night,
everybody.
Enter funding with the PBS News app.
So someone has a TV maybe or a radio in the background. That might be a little louder than what you're intending it.
Right, when you get started, Sherita, Lindsay's gonna mute all of us, so you won't have any interruptions.
Oh, okay.
Yeah.
Oh,
just to put you at ease, yeah.
Hi, Eileen. It's Jill.
Jill.
Hi, Jill.
Hi, Sharon.
Hi.
Did you introduce my daughter, Susan, to Eileen?
No.
Linz, just wave your hand, honey. That's my daughter, Eileen.
Hi. I'm an old friend of your mom's.
Very cool.
Which one? This one. Oh. Yeah, cool. Yeah, they went to school together.
Amy's on my board, everyone. Hi, Amy.
Hi, Sherita. I'm looking forward to
No
your
pressure. Now I can't mess up at all, everyone.
very strict.
Awesome.
Okay. 39. Yep. 3 more minutes to
Hi,
go.
cousin Cheryl Karsh.
Hi, honey. How are you?
This is my wonderful cousin Cheryl Karsh, who I adore, and she worked for the Red Cross for years, and she's retired now. And she was with us last time too.
Yeah, it was a wonderful presentation.
Yeah. I love all the connections in your group.
Yeah.
Yeah, it's Rochester.
Up to 40. Okay. And Jill is her mother and daughter.
So I know we have some folks from Asbury United Methodist Church.
Oh,
there.
Good. Is Jackie Nelson coming tonight?
I believe she is.
Oh, good. Okay.
So for those of you from Asbury, we share another connection. The Baby Love program that was in the East Avenue building on the 2nd floor of the church is one of the programs that Healthy Baby Network contracted with for prenatal care. So RAIN also did a project there, and so it's been a nice connecting point for some of our partners. We also used to rent space, and in 2017, I believe it is, we did our annual meeting in your welcoming hall in the church off to the side. So lots of connections to Asbury.
That's great.
Sharon Burke is on the call. She's the current chair of RAIN, and also a coordinator from St. Joseph's Catholic Church.
Everybody.
Sharon.
Hello.
Hi, Joyce. So good.
Welcome.
Nice to see all your faces.
Hi, Sharon.
Hi, Renee.
Hi.
And Sharon, Silvio, and Beth. My goodness, I haven't seen all of you in so long.
I know. We miss you terribly.
Jill, I see.
I know.
Hey, Lindsay.
Hi, Sharon.
Well, I'm going to get started. I would ask first if everyone can mute themselves, and then stay muted until Sherita is done with her talk. So, good evening, everyone. I'm Susan Stanger, and I'm a member of Temple Sinai. On behalf of my small but mighty committee who worked on this series, Judy Schwartz, Donna Goldberg, and Sharon Silvio, we welcome you. In addition to muting yourself, during the talk, the chat is going to be turned off. Sometimes people find it distracting, so we're going to turn it off and then turn it on towards the end of the talk. And you can share comments and questions at that point. And if we want to share any resources, we can put that in at that point as well. The presentation is being recorded. So at our first committee meeting, I asked, what brings you to the issue of racism and health disparities? My answer was LaShonda Hazard, a 27-year-old healthy, Black, expectant mother who came into Women and Children's Hospital in Providence, Rhode Island with severe stomach pains. They checked the baby, did address the stomach pain. Did not address the stomach pain and sent LaShonda home. The next day, LaShonda returned to triage in excruciating pain. She was heard to say, "I need help. I think I might die." LaShonda Hazard's concerns were dismissed, and she and her unborn baby died later that night. I share this story and say her name because, to quote Simeon Bannister, to be the healing, you have to acknowledge the injury. Mm-hmm. So I turn this over to Judy so she can introduce our speaker.
Well, the Social Action Committee of Temple Sinai is very honored to present Sherita Bullock, the second speaker in our series, who will address racism and maternal health disparities in our community. One would imagine that all pregnant women and those about to give birth would receive the same high level of medical care. Oh, if that were only true. One would also imagine that newborns and infants would receive the best medical care to heal them and keep them healthy. The color of one's skin determines their level of care. Sherita Bullock, the executive director of Healthy Baby Network in Rochester, and fondly called the Baby Lady, will share experiences through her work that will perhaps sadden you, but also uplift you. Healthy Baby Network is changing the future one baby at a time. Sherita is the one to see that this is true. She is the gentlest, sweetest person who cares deeply about moms and their babies. When you hear her, you will just imagine her sitting on a porch in a rocking chair, cuddling a newborn. Please help me welcome Sherita Bullock.
Judy, that was one of the absolute best introductions I think I have ever had. That sitting in a rocking chair on a porch, cuddling a baby is my most absolute favorite thing to do. I'm just as happy to sit on a floor or on a couch or anywhere that there is a baby that I can cuddle. Is how I got the name Baby Lady. But I want to say to you all, I want to thank you first for inviting me to come. As Judy said, and Judy has very quickly become one of my absolute best friends over email as we were talking about this conversation, but also just sharing our heart around the topic. And I want to let you all know that this topic is very personal for me. Back in 1997, when I came to what was then called the Perinatal Network of Monroe County, I was a young mom. I wasn't a teen. I was 23 when I had my daughter. But I also was told that I was high risk. I didn't understand why I was high risk. No one ever explained it to me. I delivered my daughter preterm and low birth weight. She came early and very, very small. She was 4 pounds, 6 ounces when she was born. She was delivered at St. Mary's Hospital because St. Mary's back then was actually a functioning hospital doing deliveries, and then transferred by ambulance to the NICU at the University of Rochester, where she stayed for 5 days. I was not the first person to hold her. I was not the first person to touch her. I was not the first person to feed her. And when they released me 2 days later from St. Mary's, they also did not transfer me with her. So when I was released, I immediately went over to the hospital. And when I walked into the NICU, I literally walked up to her incubator and just began to cry. She had had part of her head shaved. She had an IV in her head because she had had one in her foot and one in her hand. And what had begun to happen was that when they put the one in her hand, the fluid started to leak through her foot. So they placed an IV in her head. And I was not at all prepared to see that. I was a mess. And a nurse came over and said to me, "Sweetie, just step back and look around. She's the healthiest baby in here." And in that moment, as I stepped back and looked around at twins who were sharing an isolate, at other babies who were tinier than mine, I began to realize, wow, for, really as breathtaking as this is, it's manageable. And I was able to breastfeed my daughter. I was able to visit. We brought her home 5 days later. She is now 26 years old. She stands taller than me and she's healthy. And I say all of that to share with you all that this is it's a really daunting issue. It's one where, we'll talk a little bit about fairness and equity, where there's just not a lot of fairness and equity to it. It's a difficult conversation to have because largely we don't have really good conversations about issues of race. We don't have a language really to do that. And so people do what I like to call shelter in place. And if all we can do when we're having these conversations around race and equity is to shelter in place, and we can never get to the real conversation of the origin of our bias and the history and all the things that are wrapped up in it, then we really limit our ability to be successful. This is an issue where we need all hands on deck, all hearts and minds gathered together, moving, one accord, same steps, same pace. And, it's a difficult conversation. So I applaud you all for being bold and being willing to have it. My prayer is that I inspire you all to ginormous action together, and that this is the beginning, like my new friendship with Judy, of us beginning a relationship together. That's how we undo some of the damage that has been done. That's how we come to understand what our part is in this issue and what the work is that is before us. It's not on me or for me to tell you all what your gifts and talents are. You all know those. All I'm asking is that you put those to use in the direction of saving moms and dads and babies' lives. This is something that we can do. And if I did not believe that it was doable, hey, Mr. Schwartz over Judy's shoulder, if I did not believe that it was doable, I would not be dedicated to this. I am known for this issue and for being the baby lady because this is not a 9 to 5 or an 8 to 6 or a Monday through Friday job for me. This is my life. It is my mission. It is my purpose. I have a healthy baby girl that reminds me every day that this work is doable. And I see amazing things happen in the work that we're doing in our office. So I'm gonna walk through my slides. If I do this properly, I've left about 25 to 30 minutes for us to really talk. I wanna hear how this presentation lands for you. I wanna hear about the ideas that you have. I wanna answer questions and really engage with you. And I want you to know that this is a safe space. This is not a situation where there's a question that you cannot ask me because you are fearful that I will take offense or that you will somehow hurt my feelings. That is not the case. This is a discussion that I'm going to facilitate and lead and share some information, but then we're going to talk about it. And that's really how I believe we create change and how that change is lasting. So I hope that you'll come out of this conversation at the end a little different than how you came in, that you'll have some ideas and some challenges, and we'll just go through this together. So Lindsay, my tech guru, my savior and friend, if you would put up the slides for me and we'll just walk through. I hope you all have something to write with and can take a note or two. And I, would say that I hope to inspire, something that you want to learn something more about. But also on this slide is my email address. And so you can email me, probably the quickest way to get a response. But I'm here. I'm hoping again that this is a beginning and not an end. Lindsay, if you go to the next slide, please. I want to tell those of you who don't know a lot about the Healthy Baby Network a little bit about some of our programs and the work that we do. And so we provide perinatal education and birth preparation for mothers and for dads. Pre-COVID, we did this in their homes. We've learned, like everyone else, to move to a virtual forum. So we've been using some FaceTime and Zoom for these sessions. We provide outreach and referrals for connections for parents, both moms and dads. Again, we used to go out into the community and do this in places like laundromats and grocery stores and hair supply stores and the bus station and any place where people would gather. COVID has kind of changed that. So now we're, getting into other people's Zoom meetings. We're doing a lot of posting on social media. We are trying to connect with other agencies as a referral source. We provide health education on a variety of topics connected to pregnancy and birth preparation, and also as to how pregnancy links to other topics. So homelessness in pregnancy, substance use in pregnancy, nutrition in pregnancy, all things that impact one's health. We have a Black Doula Collaborative as a structural intervention to systemic racism, which really provides that closer touch of support and assistance for families who are pregnant and birthing and in the early postpartum period. Our doulas also go to the hospital and deliver with moms if that's something that moms want. We have a fatherhood program that is raising the issue of the importance of engaged fathers, as well as providing prenatal education for dads in a group setting, also done on Zoom. We've had dads from as far away as Japan, which wasn't initially the plan. We were trying to engage dads in Rochester, but we had some dads from Japan and one from Texas reach out. They were both gonna be first-time dads, and it wasn't costing us anything or our funders anything for these dads to participate, and so we allowed them to. And then in addition to that, we're also working to work with other groups, churches, fraternities, schools who have fathers or fatherhood programs engaged to provide services and support to them. And then we use PeerPlace as a web-based system to collect and report our data. And so we also use it to analyze our program outcomes and for quality improvement. Next slide, please. Oh, the pictures that are, or the points that are coming up on the side are annual events that we do. Traditionally, we do them in person. We've had to shift a little bit and do them online. And we're talking about some creative things. This year, Healthy Baby Network turns 25. I have been with the agency 24 of those 25 years. And had the awesome blessing of working in every program related position. And I believe that has really prepared me to be the executive director and a lead in our community when we talk about maternal, paternal, and infant health in our community. Could you go to the next slide, please? So I asked this question at ABC, and I can imagine the look that some of you must be giving me when I ask you, who owns Black women's bodies? And I know that our go-to is for many of us to say, well, of course, Black women own Black women's bodies. So my question in response to that would be, then why don't we listen to them when they talk about their bodies and when they talk about their health? When we talk about the issue of Black maternal mortality and morbidity, these are moms that die during pregnancy, during delivery, or shortly after delivery. The two things that are really significant for me is that when you talk to families who've either had, or women who've had near misses, or families who've actually experienced loss, the common theme is that we knew something wasn't right. We didn't quite know what the something was, but when we tried to engage our medical provider to do something, we couldn't get them to act. And we hear this theme repeated over and over and over again. Serena Williams is a tennis player who uses her body really to play the game of tennis, but it's really her tool, it's her vehicle. And she knows her body well. So when she was in the hospital having her daughter, she knew that she had issues with blood clots in her lungs. And so when she began to have problems breathing, she, would tell her medical team, I need a test. I need to have an x-ray of my lungs. I need to have it with contrast so that you can see the clots because they're small and sometimes not really visible on a regular x-ray. But if you run it with contrast, you will see them. And over the course of the days that followed her delivery, 4, she could not get them to do the exam, and her breathing continued to get worse and worse and worse and worse. At one point, it got so bad that she found herself in her hospital room alone. She crawled out of her hospital bed across the floor and grabbed the first nurse in the hallway. That nurse then was able to get other people to come in to assist her. They ran the test, but even still, with all of her information, all of her knowledge, and really with no consideration for whether or not the test would be paid for, she wasn't using an insurance product. Serena happens to be married to the founder of Reddit. He's a multimillionaire. So with no regard for payment or any of those kinds of issues, she still was not able to get her medical team to run the test. They ran the first test without contrast, couldn't see it. And then to sort of satiate, I'll say, her husband, they ran it with contrast and were able to save her life. We know that she did survive, but she had what we call a near miss. And again, this theme of, we knew that something was wrong. We tried to get our provider to act. We could not get them to move at our word. And this is a story and a theme that repeats itself over and over again. I don't know if anyone had the opportunity to watch All Rise last night. This was an issue that was on All Rise. All Rise is a TV show where the lead character, Lola, is a judge, and she sees many cases, and she's known for really being committed to people. And so going the extra mile to try to have equity in her justice. And they were trying the doctor for murder because a mom had died during childbirth. And her husband was saying, we tried to get him to work. We tried to get him to act. We explained over and over again that something was wrong. She was almost belligerent with him, trying to get him to act. The doctor on the stand said, I'm so sorry that I did not get to know the woman that you described. What I experienced was a woman who just did not trust me. She wouldn't listen to any of the things that I tried to say. She was confrontational. She was, and he said she stopped just short of being abusive. And he looked right to the jury and said, I did not intend this. This was the worst case scenario in terms of outcomes that could have happened. I did not get into medicine to harm women. I've delivered hundreds of babies. Please don't take that away from me. And the reason that I say that is because I don't want any of you to walk away with the impression that I'm pointing a finger and blaming medical providers for what's happening with maternal mortality and morbidity. I'm pointing the finger back at us. And by that, I mean that we have not done a really good job at doing sensitivity training, at doing bias and understanding and being able to listen and to go, to be able to hear when someone is pointing out something that may be a flaw in us. The nature of bias is that it's hard for us to see. And so unless we do better, unless we motivate ourselves to change the systems that we interact in, our health systems, our employment systems, our human service systems, our political systems, unless we take that onus and that responsibility, things will continue to happen. And what we have seen is that these rates are escalating. So when we look at infant mortality, low birth weight, babies that are born small, babies that are born too early or preterm, and Black maternal mortality and morbidity, what we see are themes in Black women experiencing these things at 3 to 4 times the rate of their white counterparts. When you adjust for address and income and all of the medical situations and circumstances, we find nothing that explains it other than the color of skin. And the reason that this is important is because we cannot continue to just do what we have done to improve all of the systems. We have to target Black women's health. And we have to target Black pregnant women with interventions specifically geared to them so that we are able to improve their health, not by doing the same thing for everyone, because everyone doesn't need the same thing, but by focusing those strategies and interventions that we know are successful with women and that show outcomes, particularly for Black women. Lindsay, would you go to the next slide, please? So transforming our lives and our health, how do we do that? Well, first, we have to look at our continuum of care and disease management. Right now, our systems are set up and our hospital systems are set up when you have a hurt or a problem or an issue, you come, you diagnose that issue, you treat that issue, you go home, and then you manage that care. We have got to become much more proactive about looking at what is the standard of health and what specific services do we need for individuals that help us be proactive versus reactive. We, number two, have to get honest about the legacy of chattel slavery in the United States. There are people among us who will say, I don't understand what the issue is. Why can't Black people just get over it? Well, we can't get over it because we haven't dealt with it. You can't just move beyond something unless it's been dealt with. And that's an issue that, really is on all of our shoulders. We've got to address racism, number three, and all the ways that it shows up and it's represented in our systems, our educational systems, our justice systems, our health systems, our employment systems, our housing systems. We have to, number four, value our community assets and intellect. Our community has strengths. The people and the relationships that flow between and among those people are key strongholds that we just oftentimes don't acknowledge and we don't leverage. We started this session off with so many of you saying hi to each other and connecting on a personal level, person to person. I'm so-and-so, I haven't seen you in so long, it's good to see you. Those are assets and strengths that are available in our community. We have awesome programs and agencies like mine that are doing good work that often are underfunded, are tenuously funded as we have shifts in government and it threatens the entire existence of some of these organizations. We've seen some close. And then we have, a group of intellect because we have all strong minds, creative people who are able to come up with all kinds of options. So we do our best when we're together with our best efforts, our best energy, working the same direction. Number five, reevaluate information and data. Oftentimes when we go into the hospitals and as medical providers are asking for the story, we tend to provide all kinds of screenings and tests, and we use that data to diagnose. Well, the people who come in with those issues also have data. They have the story of what's been going on. They have the story of different things that they have already attempted to do, and people who are connected to them, who are their support people. That's information and data too. So we need to give that the same weight that we give some of our test results, because that data that people come in with oftentimes help explain what a test or an exam or a screening is saying. We have to address and prescribe individual and collective work. And what I mean by that is, so far when we've talked a lot about diversity, we will do trainings. And when that training is complete, you get a certificate of completion. And it's really about the demonstration of were you able to sit through the training. Oftentimes we're not asking for proficiency in the material. And so we need to be able to evaluate some of these things by demonstrated proficiency. So we need to recalibrate that. And then we need to intentionally and purposefully engage Black men and fathers in health, in maternal child health, which completely as a term leaves dads out. And in the work that we're doing, because so often they are the keys to support for our moms and for their partners and for their wives. They're advocates for their children. They bring a calm into the space. And there's just no replacement for a father's love when you're nurturing and trying to develop an infant. So we've got to be honest about that. And we have to be intentional and purposeful. Lindsay, would you go to the next slide, please? So when we talk about, well, what's health and what drives death or near misses that we're talking about, I want you all, I'm not going to go through each of these. This was to just show you a myriad of some of the things that get under our skin and impact the quality of our lives and our health. And so I talked earlier about sheltering in place, but even the term maternal child health completely eliminates fathers out of that equation. And then oftentimes we, we pay so much attention to women when they are pregnant that we oftentimes don't screen for all the other things that impact their health and their outcomes. Cavities inside of a mouth is an precursor for preterm delivery because there's an infection that is active that could make a woman go into labor early. The same with diabetes, other kinds of infections in the body, and heart disease. So a lot of times if we would consider, all of the things that really drive health and try to begin to incorporate them all across our systems, we require that children have, or that people have medical insurance. You have to have it if you have a child who's entering school, you have to have it in college. We ask for it at pre-K. Some employers require that if you are not using their insurance, that you demonstrate that you have insurance somewhere else. So, but we don't actually require that people access that insurance and go to the doctor and have screenings. And I'm not saying that it's something that needs to be legislated, but that can be a community norm that we begin to work on. And so one of the things that we do when we're doing intakes is we ask people, one, do you have insurance? And if their answer is no, we help them get medical insurance. But then our second question is, when was the last time you were at your doctor? When's the last time you saw your doctor? And if people say, well, I don't have a doctor, then that becomes one of the targets that we prioritize and work on. So we've got to begin to think about what our systems are and where the opportunities are to improve and transform them. Lindsay, would you go to the next slide? So why does all of this matter? And I certainly do not mean to suggest that all babies who are born look like Joseph, all white babies who are born look like Joseph, or all Black babies who are born look like Elijah. But what I'm saying to you all is that when we begin to factor in disparities, we have larger percentages of babies being born, white babies being born who look like Joseph, and Black babies being born who look like Elijah. And when you start life this way, when you start life like where Elijah is, then how do we begin to work actively and intentionally and strategically to catch Elijah up so that he can get to where Joseph has started? And that's the point of this slide. Lindsay, would you go to the next one, please? So a lot of times we talk about the difference between equality and equity. And equality, everybody gets the same thing. And that's an idea that for a long time was the goal for a lot of us, both in our jobs and in school. We want everyone to have the same opportunity to start. And we didn't talk about really what equity is. And equity really demands in some cases that there's more, unto each according to their need. Sound familiar? So in the second picture under equity, we see that in order to get everyone, if the goal is for everyone to see the game, then some of us need nothing. Some of us need a little assistance. Some of us need a different kind of assistance. Lindsay, would you go to the next slide? And we're so quick to point the finger at the fence, but I really love this slide because in the third picture, you'll notice that the wood fence has been replaced with a metal fence. Now, if we were in a setting where we were all together, I would look you all earnestly in the eye and I would ask you, what is the purpose of this last picture in this fence? Because in baseball, we need the fence, right? The purpose of the fence is it stops the balls from going off of the baseball diamond. So we need the fence, but it doesn't have to be a wooden fence. This metal fence does it, and it does it in a way that you don't have to make special provisions for anyone because it levels the field for everyone. And this is the goal with equity. Unto each according to their need, but it shouldn't be that we have to point out or it has to be visible of what that accommodation is. Next slide, please, Lindsay. So when we start talking about the way forward, we really are talking about strategic interventions. And here's the real meat of my presentation, right? It's really to come back and say to you all that as we think about these issue of racial health disparities, and we think about what's the difference and how do we reframe, how do we do something different? I'm asking that we, one, always center on people, always. Let's take a moment to set aside, whatever the forms are. Yes, we have paperwork or screens that have to be filled out. Let's always take a moment to focus and center in on the people who are before us, who are among us, who are the folks that we most want to improve their health conditions or their life conditions or whatever it is, but just take a moment to center in on them, who that person is. That too, we begin to frame our relationships in terms of lifelong impact. Let's move past the transaction of why some folks may come to be in front of us, whether it's a medical provider or even a cashier at a store. Yes, you have a job to do, but if you understood that that same person that you're seeing right now in that moment is going to be someone that you're going to pass in the grocery store, that you're going to see when you're at the park or moving through our community. It always kind of irks me a little bit when people say, oh, there's a community of providers, there's a community of consumers, there's a community of parents. And I say, no, we have one community. We have subpopulations of people, but we're all moving through and experiencing our community together. So let's frame our relationships in that way. Then number 3, establish and nurture relationships with others who are different from you, however it is you define different. If you look at your friend circle and everybody is a middle-aged brunette home worker, and maybe they're home because they aren't employed, or maybe they're just working from home because their offices are closed because of COVID. But if everyone has that same experience, that you find people who are different from that, and that you nurture relationships with them and you get to know them. Because I personally believe that the way that we begin to address bias and this disconnect that we feel when there's a line and we find ourselves on one side and other people on the other side, whomever those other people are, is that we don't have the experience of valuing on some level that other person or their condition. And that when you begin to do that, then you can ask people about their culture and how they express it. Everyone who shares a culture or a racial or ethnic identity does not express their culture in the same way. So you have to ask and you have to learn about that person and that expression. And it will open your minds to all kinds of possibilities and combinations and thoughts. So that number 4, we can be transformative. Transformative is a process of reconsidering everything you've learned to understand what is true. And so, I say that and sometimes I get little smirks like, what do you mean? And, it's our parents, how many of us grew up with parents. And I don't mean to oversimplify, but I want to make the point quickly in a way that I think that people can rally around. So most of our parents told us, you don't run with scissors because you could fall and hurt yourself. Well, sometimes you have to walk expeditiously with a pair of scissors. Doesn't mean that our parents were wrong, but what I'm saying to you is that some of the stuff that we learned was by deficit of the things that people who taught us those things. And so we have to be willing to reconsider that. And then we need to really respect people, especially when they disagree with whatever your opinion is, because there oftentimes is your greatest opportunity to learn. And I'm not saying that everything is going to be true. But I love to sit and talk with people who disagree with me about things because I understand, it gives me the opportunity to understand and learn why it is they disagree. And that understanding helps me learn what I'm working with in the rest of our community, because there are other people who will think those same disagreements who may never tell us, may never step up to say anything. And so number 5, recognizing our community as a valuable unit of identity, and then seeking to build on the existing strengths and resources that are there. And this really goes back to just understanding that our community is full, it's a rich tapestry of colors, of different races, different ethnicities, different skills, different orientations in terms of people understanding different things in different ways. Lindsay, go ahead to the next slide. And when we do that, what it presents us with is an opportunity to learn something that we didn't know, or to have the opportunity to experience something that we hadn't considered before. So when we talk about addressing racism in all the ways, whether it's personal, mediated, interpersonal, or structural, how it presents in our interactions and our systems, we begin to understand how things play out very differently for other people in our community. It doesn't play out the same way for all of us. I say to people often that, you know, I show up as a Black woman first. Yep, I'm an executive director. Yes, I'm relatively smart most days, depending on the topic. Yes, I'm eloquent in language, but I show up as a Black woman. And when people say things to me like, well, I don't see color, that makes me really nervous, because I think that, and I understand the intent is to say I don't treat people differently based on their color, but to say that you don't see color is a different statement. So we've got to be able to address how our policies play out differently for people, and when that is attributed to race, to do something about it. Number 7, to commit to not laugh at, share in any way jokes that disparage people racially by their ability, gender, hair color, or otherwise. The reason that this one in particular is so dangerous is because we're so quick to click forward oftentimes, but it desensitizes us to other people's struggles. And being desensitized, to me, treads right along the area of bias, because you don't see it. And then you let things slide and it's not hurtful until it is. Number 8, worked actively every day to change the culture of the system that we live and work in, so that we're beginning to think about new alignments, new connections, new networking strategies, new ways to build supports for people who are vulnerable, for people who are not vulnerable, who are friends among us, but need to be strengthened or supported through something. And that we have the opportunity to make that a legacy thing, just simply meaning that it lives beyond that interaction. To number 9, think through our actions, interventions, or projects to consider potential unintended consequences. We have, awesome programs in our community that sometimes don't think about the unintended consequences of how they do business. And so, think through those things, talk with others. Everybody can't be the leader in the group, because then you don't have a follower who tells you that important information that you need to know. So you need people who think critically. You need people who are cheerleaders. You need people who have influence. You need people who are really knowledgeable about whatever the process is that you're doing, because you need all those things together working in concert in order to promote positive change. So number 10, commit to do your own work. And, when you're talking about issues around race and racism, the reason that it's so important to do your own work is because you can start off and half do something and then injure someone else. And when you then ask the person that has been injured to explain to you why they're hurt, you injure them more. And this is something that I want you all to understand, that whether, whatever the lens is that you find yourself in, so whether it's gender-based, whether it's racially based, whether it's based in ability, that when you are the person who is hurting, to have to explain to the person who hurt you why they hurt you is another insult on top of the injury. And so we call those, when we're doing work around race, macro and microaggressions, just depending on whether it's systemic or large, or happening from a supervisor, or whether it's something that's happening in a day-to-day interaction with a peer, or in the course of life. And so what happens is you make a decision, particularly when the person doesn't know that they've injured you, on whether or not to take on the work of educating them, which then becomes another layer of processing to do for the initial injury, and then the injury of taking on the topic. And there are times where you just have to make the choice. And that's something that is done individually by each person in that circumstance. And we, no one of us has the right to judge that for someone else. So, be careful when you're learning, to do your own work, and to start off in a way that allows you to build some strength, some knowledge, and some sensitivity around whatever it is, the topic, whatever topic it is you're addressing. So whether it's trauma or whether it's race-based or something else. Would you go to the next slide, please, Lindsay? So create a tribe. This is my favorite. A tribe is a group of people who are setting out to do the same thing that you are doing and will do it with you in love. And why this is so important is because, relating to number 10 about being careful to do your own work and not create injury, your tribe will point out when you are failing horribly at something that you are setting out with the best intentions to do, but they can do it in a way that is sacred, that will not injure you. And so, and we need that. We need people who will celebrate us. We need people who will call us to the carpet in truth and in love. And we need people who will, you know, join along with us and say, yep, I'm going to read this book with you. Let's read the first 2 chapters and then talk about it. Number 12, and I realize that this one can be sensitive, and I want to remind you all that I mean this in love, but talking to young people about relationships, values, and sex so that they make informed, value-based decisions before they're ever in a situation where they have to comply with what someone else's wishes are. So in human services, we call this preconception health education, which is just about education before someone is pregnant. But one of the things that is a common theme in so much of the work that we are doing is that we have adults, men and women, who feel like they didn't have a choice, that they found themselves pregnant and they found themselves in situations. And I want us to be able to have strong people and adults around youth who love them, who support them, who can share their values with them, and who often are the ones who are teaching values to them, to be the folks who speak first and have their first voice on topics that are this sensitive. It comes from such a loving place. And I think that that's done, you know, best by adults who love them. And so whenever I have a group of adults and I have the opportunity to say so, I try to say that. I was involved in a group that really worked to repair relationships between mothers and daughters. And so often we would find that things that moms were doing out of love from really, really good places, sometimes are just getting lost in translation with their daughters. And I would believe that the same is true of men and sons. But, you know, when you have loving adults around you who want your best, who want you to be able to sky's the limit, who prepare you for what you will encounter in life, those make for the most informed and best decisions. So number 13 and 14, the Black Lives Matter movement and unnatural causes. These are things that are going on in our community. Unnatural Causes has a website and it has a toolkit that talks about the causes and drivers of health during pregnancy. And it also talks a lot about racial health disparities. And so when it comes to pregnant women, educated, rich Black women tend to have worse pregnancy and birth outcomes than uneducated, poor white teenagers. And a lot of that has to do with the interaction of racism into the health system, into their employment structure, the stress that all of that creates, and what stress does to the body. And Unnatural Causes does a really good job of walking you through all of the science and some of the stories around that. The Black Lives Matter campaign really, and I understand that this is very controversial. I hear people say, white lives matter, all lives matter, blue lives matter. And, in response to that, I, just want to share that, in our community, what we are seeing is a difference in how lives matter play out for different people. And so saying Black Lives Matter is not about disparaging any of those other groups. It's about simply saying that we have too many Black people, Black women, Black children, Black men who are dying of preventable deaths, and that there's something that we can do about that. And when we can, we should. And so that's really what that campaign is about. And then 15 is, really share something that you've heard today, something that struck you, something that moved you, something that is sitting with you with someone else, because talking about it, and do that tonight. Don't wait until tomorrow. Do it tonight, because that oftentimes is how we move to change. That's how we move to be able to discuss things that have been set aside or hushed, or things that we typically traditionally don't talk about. So the way that we begin to talk about them is to share them, and I say with a close friend or family member, because oftentimes those are safe spaces. And so you can say what you need to say without fear of judgment or retribution. And that's the way that we heal. Lindsay, would you take us back to the screen where we can all, oh wait, can you go to the next slide? I'm sorry, I forgot the reason for the trip, you all. This is why we do it. And this is why this work is so important. Our babies have the opportunity to grow and to love and to be strong adults in many different ways. And so this is why I do it. I work hard for all of the babies. Would you go to just the last slide? This last slide has just 3 things. I wanted to get us started on our discussion. And so I wanted to offer for you, and thinking, for a moment about our conversation, what comes to mind for you? What's standing out? What's resonating? What things stand out as challenges? And then what should we do about these challenges? What are some of the things that we could do to improve them? So now, Lindsay, would you please take us back to the gallery where we can see each other? Well, smiling faces. I love smiling faces. We're still on my computer and presentation group. Can you take us back to the one where we can all see each other? Or is that something that I need to do?
So if you, in the upper right-hand corner, if you click on view, and then
okay, got it.
Gallery. Okay.
There you all are. Thank you, Lindsay, so very much for being my on-the-spot tech guru, for helping me get through that presentation, and for walking me through to support this presentation. I really appreciate all of your help. I know that up to an hour beforehand, that was not on your agenda for tonight. So I appreciate you jumping in to support me in that way. Thank you so very much. So everyone, I would love for you all to unmute yourselves. I would love to hear what your thoughts are. I would love to hear, what things stand out as challenging or difficult. And I would love to hear different things that you think that we could do about those challenges.
I wanted to say something, but I thought maybe I should let someone from Temple Sinai go, since it's
no, break the ice, Amy. We need an icebreaker. Go for it.
Okay. I mean, whenever I hear you speak, Sherita, I am always just thinking amen in my head. So amen to everything you said. But one thing that really resonated with me that, maybe I haven't heard and talked with, maybe I've heard it in other ways, but the way you put it of finding your tribe and being able to, run things by them instead of, just having those people who, you can trust, who you can maybe screw up with, and they will tell you, and it's okay, and they still love you, instead of going to a stranger and being like, I want to be a better person, tell me how to do it. Personally, to me, having that tribe to do social justice work and, just getting through life in these last 4 years, it is really crucial, I think. And I was talking with a friend of mine who, she was my college roommate, and she is a person of color as well. And she was like, I have this one white friend who lives somewhere. And she's like, I don't understand. Like, she has no other friends of color except me. And, now they live in different states. And she's like, so she just like calls me or texts me or, whatever, whenever she has a question. And I just want to tell her, like, go make a friend where you live. And I understand, like, sometimes that can be hard. And I think, as I grew up, there were mostly white people around. And so that's who I became friends with, right? And so if you're just used to that, and if you're a person of color, you see it differently. And maybe it's easier to try to make friends with people different from yourself, or, who have different cultures. But I can see where it would be hard if you're part of the dominant culture, and that's just the way it is, right? So I don't know, just your talk made me think about a lot of different things, and how tribe is important, and having different people in that tribe and different types of people with different views is important. So thank you.
Yeah, absolutely. I was sharing at the beginning of this presentation that I used to do present to the School of Nursing a lot. And I had a young woman once tell me, she was 19, and she said, you know, I was never around Black people until I came to college. And I thought, what? And I asked her, I said, how can that be? And she said to me, I live in a small town where everyone is white. And the only time growing up that we left that town was to go and visit other relatives who also lived in small towns. Or we went to their house and we stayed at their house. We didn't travel or do a lot of different things. And so I was never around another Black person, or I was never around a Black person until I came to college. And I thought, wow, what an experience that must be. And so we talked a little bit about different things that she had done to make friends in the middle of this presentation, but it was something that really struck me, and it struck her, because I was saying to them that it was really important for them to make friends with people who looked like some of their patients, but who were probably never likely to be their patients, so that they would not have impressions based on their interactions with people in the hospital that all the people from whatever that group was lived, act, and moved like the person who they were treating. And so, you know, we would get into really interesting conversations. I also gave them my email and told them, you know, I can be your person, call me, email me, let me be your person, because I would much rather be your person and have you say something quote unquote wrong to me than to risk you doing that in the setting at the hospital and doing that to a patient. One of the things that, you know, they were taught, and this isn't happening anymore, but one of the things that medical students used to be taught was to build rapport, call someone by their first name. And that is something that's really offensive to African-American elders, for a young person to walk into a room before they were given permission to call you by your first name and just start talking to you using your first name. And so that's one of those things where something that we were teaching to really be a good thing really had a really bad unintended consequence. Mm-hmm. Others? I'm anxious to hear what others of you think about the presentation or what's resonating for you.
Sherita, it's Judy. I found it really very, very sad and depressing when you said that Black women aren't listened to. And I mean, and when Susan gave her opening story, you know, what is being done to try and correct this situation? What can we do to help correct this? Because it'll save lives, and it's just so sad.
Yeah, so this is a tough one. I can tell you some of the things that I'm doing, but let me also tell you that the other side is when I talk to medical providers around what are some of the causes and drivers, what they tell me is that oftentimes moms show up to the hospital having had little or no medical care before their pregnancy with health conditions and issues that were never either identified or managed. And what happens during pregnancy, when there is a death or a near miss, that's really the consequence of that poor health condition. So I arrive as both not someone who's recently had a baby, remember I told you my daughter's 26, and not a medical provider, saying, how can these two things be so dramatically different all at once? And what I have come to understand as we've been doing this work is that there are cues, for me at least, that some of our, that some of our medical providers look and who hear the stories and don't identify with those women on a personal level. So what happens is that as this family or this mom is explaining conditions, they're looking at the sum total of all of their medical experience rather than connecting right then in that moment with that mom or with that family. And so one of the things that we're doing is we are, I've been calling this my yet to be named committee. And we're centering together all of the medical professionals who are likely to touch a pregnant woman during her birth with women who have recently given birth, to really peel that back and figure out what's going on in that moment for medical providers and how do we create better patient-provider relationships that sort of decommissions all of the medical expertise that sometimes screams louder than what the patient is saying. So what I would say for you all, in opportunities that you have to be with pregnant women who are seeking medical care, particularly vulnerable women, and I will tell you that most pregnant women feel vulnerable when they are going to seek prenatal care, work with that mom to understand what her opportunities are for where she would rate her doctor. And I tell people, you can fire your doctor. And that's a notion that sometimes really blows people's minds. And I will tell you that pregnant women oftentimes don't want to fire their provider because they don't think that there's another one around that'll jump in. And so we work to really work through some strategies around that. So, you know, you've been to the doctor, you don't feel like the doctor is listening to you. Here's some things that you can do. Here, take someone else with you, write down your questions, let them know that you've written down your questions so that you have more of an opportunity. Who else is in the doctor's office who's on the medical team that you might be able to talk to? And so we don't have time to simply only do the work with moms and families. We have to do the work with providers at the same time, because in the interim, we're still losing women. So we do that work, and we really work to help people understand that we need better patient-provider relationships. And you really can't engage somebody and wanting to be in a relationship with you if you're pointing a finger at them saying, I think you're gonna kill me, right? But that's not to say that you shouldn't say that if that's how you're feeling. So it's really about saying, what are the resources around you that you can then go to for help? And it gets sometimes kind of tricky when you are, you know, if you haven't had a lot of medical care, or the last time you had it, it went really wrong, or if you don't feel like your provider is going to listen to you no matter what you say. And so sometimes that work is, you know, I've had to go to prenatal appointments with moms. And I'm learning very cautiously, because I had a provider tell me that if you go in there, and I'm going to use the language that she used for me, was if you go in there showing out, what's going to happen is that mom is going to be labeled as aggressive and combative, and that's going to go on her medical chart and follow her for the rest of her life. So you can't do that. You have to partner with providers. And that was something that really took me a long time. So I learned how to ask questions. And I would ask questions like, do you understand that the way that this is coming off for me is that I have no power or control? Is that the impression that you're intending me to have? And then my classic, and then just stop talking. And for me, you all have been through a presentation with me, so you know it took me a long time to get to, and then just stop talking. Because I want to keep going. I want to talk longer. I want to say it 6 other ways because maybe you didn't understand me. But sometimes you have to just stop talking so that other people can talk and share and can answer your question and tell you where they're coming from, so that you can build a bridge instead of blowing it up. Like grandma really had some wisdom when she said, build a bridge and then walk over it. There was some wisdom in that. And so sometimes we have to back up a little bit, take a moment to build a bridge and then walk over it.
Ronnie, did you have a question?
That was an excellent presentation. Thank you so much, Sherita. I've done some work, some projects where, you know, with low-income communities across the country. I was involved in a demonstration project, and of course this pattern, you know, was everywhere. But I even found that some minority physicians, some minority providers themselves didn't have a really good understanding of their patients. You know, if somebody was not compliant or somebody just didn't show up, they didn't understand some of the other reasons that that were part of the problem, you know, lack of transportation, no babysitter, all kinds of things. Do you find that you say you talk with providers? Are they receptive? Are they understanding of what you tell them? You know, they come in, I think lots of educated people have these preconceptions about, you know, people, and until they get a real good understanding of the individual patient and what that person's obstacles are, and their social conditions, their background, trauma, you know, the traumas they faced, and they talk a lot about, I think, trauma-informed care. I'm just wondering, how much education do you have to do with the providers?
Yeah, so ironically, there are lots of interesting things in what you said. I think that overall, some providers are not really sensitized into the day-to-day lives and the factors. When I say that our moms are living through very complicated situations, and those situations have layers of complication that are unwound, I think that language sometimes can be a barrier. And I want to offer you something, and I want to do it in love. And I realize that it's difficult because this is a very large crowd. I am very careful about language and about how we talk about our moms and dads and the parents that we work with. It's an area where you very easily can go wrong. And so I used to start presentations off and would say, when I mean Black, I say Black. When I mean white, I say white. When I mean people of color, I say people of color, and that could be anyone who is non-white. We do not really use the language of minorities anymore. And so what's important about that is if you are working to engage a population of people who are non-white and you use a word like minority, what happens is you create a power differential that sometimes makes them feel less than, or has the ability sometimes to shut down the relationship. So language is really, really careful. And I learned this the hardest way possible, sitting in a room where with actually a public health professional researcher who used the term low income, uneducated Black mothers. And I have never felt more invisible than I did in that moment. Now, yes, I'm educated. Yes, I'm a Black mother. Yes, I've worked through various levels of income, but also understanding that when you're using terms like that, they can be so loaded that the person, you may not even be aiming them at me, but the people who are sitting in the room are so impacted by the weight of some of those terms that it is hard for them to then engage. And so, and oftentimes you may not know why the person just shut down. You just know that all of a sudden in that moment, the person you were talking to completely shut down and something must have happened. So I want to offer to you all to be really, really careful about your language. And if you're not sure, like when you're meeting someone, what to call them. So maybe they, aren't an elder, or maybe they have a title and you're not sure, like pastor or reverend, and you're not sure whether or not you should use it, ask them. And you can say, I really want to be respectful. I'm not certain how you would like to be addressed. Can you tell me how it is you would like me to address you? And you can do that whether you're talking about, if it's a medical interaction and it's a patient, or whether you're in a meeting and it's a partner who's there, or just someone who's, walking in. But to really, really be careful, because there are so many power differentials and so many issues of equity that are happening, and so many things that are being challenged in the environment that we are in, that it is super easy to offend. And oftentimes people won't tell you that they're offended. They may not say anything or give you that indication. Oftentimes they'll just sort of shy away or go away or do what I call voting with their feet. And you may not see them or have the opportunity to interact again. So I just want to offer that as a, as a little nugget of relationship building. Because so much of this is about being able to build relationship, to have safe spaces to say really tough things or to explore really tough topics.
Thank you, Sherita. Beth, you said you had a comment about educating doctors.
I do. I'm having recently, unfortunately, lots of doctors and going through that myself, even though I'm and have lots of privilege. What I saw were the ways that different doctors, often different systems, worked differently with people. And I believe that some of that comes from like the culture, the hospital system. And so kind of looking at this a little bigger picture, I just wonder whether there's going to be something done kind of on that level, whether it's in medical schools or it's afterwards in a hospital environment, really helping them understand how the way that they deal with patients impacts their ability to really get good diagnosis for healthcare. And I guess I hope that that will be something that gets place.
Yeah, I can tell you that I know the Center for Community Health at the University of Rochester is working on a curriculum to introduce cultural competency, equity, and inclusion, I think is what they're calling it. And so what I saw was a notice that went out to community leaders and professionals to work with staff from the University of Rochester to write that curriculum. I also have been involved in years past in working on a curriculum for researchers. And so I was part of a group of community leaders who put together a 6-section curriculum with different presenters, different topics to work with the researchers and faculty before they applied to the university for funding. And so they would go through this class and have the certificate, and then would take that certificate with them to apply. And so I think that the University of Rochester is doing a lot of different things to really address some of these issues, and I applaud them for doing that. I get a little nervous going back to how we demonstrate proficiency around some of these things, and being nervous that proficiency means that you completed the document or whatever the session or training was, not that you demonstrated that you actually understood the materials and had ways to put them into practice. And so I think that that's a conversation that we just need to continue to have and continue to really be sure that people are clear about what it means and all the different pieces of work. I definitely speak as an expert in maternal, paternal child health, but not as an expert in everything, right? So I stick to what I know and stay in my own lane. But I also think that there are other professionals in our community who are doing this work on like that next systems level that you're talking about, Beth, who really could be of service. And so when I saw that request go out, I sent it to some folks and shared it with other people in hopes that what will come out of that really is something that will begin to do the work that you're talking about. I think that this is really a huge, huge issue in our community, but also in our country. And I think that people are really struggling to figure out how to do better. I think that collectively, all of us want better, but I think we're struggling with how do we actually do that? And so one of the things that Healthy Baby Network is doing, it's been my vision for about 2 years now, is to have a Black birthing center where families can have an all Black professional care track as a way to deconstruct structural racism. And that is not to say that only Black people will use the system, only Black people will be employed in the system. I'm saying that to really target what I'm trying to improve, which is the health, birth experience, and birth outcomes of Black women, that this is one of the things that we're going to try. And when it comes to full scale, we'll have something like a community health center. So I grew up in Rochester in the 70s where we had lots of community health centers. And so this is something that I think is a direction that Rochester is going to be returning to, again, not to be exclusive, but to target our most vulnerable. And I think that when we provide services in this big high-like way, all services to everyone, that people fall through the gaps. So if we focus in on the gaps and then provide those services that really, really bring and address the vulnerabilities, that we can begin to reduce and then eliminate racial health disparities. And then we can go back and mushroom this to scale to size for the entire community. So that's really what, my hope is. I know Ari, through some of our professional work, to do some of the precursor work around that. The Greater Rochester Health Foundation was the first organization locally that funded services for fathers, and they weren't prescriptive about how we did it. We had an idea, we had the components together, We talked with staff at Greater Rochester Health Foundation about what it was we were thinking and what we had in mind. And as a result of them believing in the work that we had proposed to do, we have Rochester's very first fatherhood community health educator. And we've had community health educators in our community for over 30 years, but we've never had one focused on the issue of fatherhood, focused in on dads. And so in October of 2019, we hired the first staff person. We now have 2. This year, we'll be adding 3 more, solely focused on dads for the health improvement and educational and life success and development of their children. And so those are the kinds of things that we're, really starting out to do, piloting in a small way, that we can really bring our best thoughts together around with people who support it, and then scaling it up to size. That's why I was so excited when I saw Ari down on the screen. We've done lots of work together for many years.
Joyce Herman.
Joyce, you're on mute, Joyce. Joyce?
Got it.
Okay.
Sorry. Yeah, Sherita, thank you so much. This was a heart expanding, mind expanding, just absolutely brilliant. And with all of the challenges and the pain that comes with it, there's so much optimism that comes out of the way you're operating and thinking in both big and little ways. I was struck by, like, in the 1990s, I actually worked with the doctor who was leading residence training to do cultural, to get some cultural understanding. And so that was in the 90s. So when I hear you talking, I was feeling, oh my gosh, there was a sensitivity there, and and yet all this time, how tremendous the challenge is. But a question I have is, I am under the impression, and I've seen, that there are more Black doctors, more Black people graduating from medical school, more Black women. I loved one of the graduations several years ago. It was like, wow, a sense of camaraderie and numbers. So do you begin to see, and certainly the Black doctors who spoke up around the Black Lives Matter, are you seeing that those changes are a good way in for changing the culture for everybody as they get to talk to their white colleagues?
That's my sincere and earnest hope, Joyce. You all, I know, had Dr. Linda Clark at your last presentation. Dr. Clark is one of the founders of the Rochester Black Physicians Network, really just trying to build support for the Black physicians across the community here. One of the things that we are seeing, and I think this is happening all across our education continuum, is that we have people who are being educated here who often will leave after they've been educated. And so that also has been an issue that we've seen with Black health professionals as well. And so one of the things that Dr. Clark and Dr. Angela Kyler, who were the founders of the Black Physicians Network, really work to do is to bring people together, to connect them to the community, and really try to create a sense of community and neighborhood with them so that they would stay after they graduated, and for a variety of reasons. I mean, Rochester is still a very racist community. I want to be honest about that. But in addition to that, a lot of people talked about, there not being a lot of nightlife, about there not being a lot of other professionals or activities or cultural things that they wanted to get involved in. And I think that, some of that, is true. But I also think that beyond that, it's really about whether or not people feel a sense of home and a sense of community where they are. And so I think that we've had opportunities to do that. I think that Drs. Clark and Kyler and the entire group have done a lot of work around that. They're also very connected to the African American Health Coalition that's run by Common Ground Health. And so there are lots of things that are coming out of it. And I think that we just need time for these things to sort of cook and be able to move along, because I think we've got lots of great things that are sprouting and things that, you know, really are happening. So, you know, again, that is my most earnest hope, Joyce. Like, we're right there together. And so, yeah. Any other questions? I'm trying to watch the chat. So when you all see me look down like this, that's what I'm doing. I'm reminding myself to look down.
I loved your equity, your equality and equity slide. Particularly what spoke to me is that when I saw the fence that you could see through, everyone benefits. It's, and that is, I think that has been the underlying message for so much of my personal anti-racist work and the work that we're doing at Temple Sinai through the Social Action Committee, that everyone benefits from us doing the work. And that slide was just, everyone can see. It doesn't matter. It doesn't matter how tall or what they look like, or everyone can see. So I loved that slide.
Well, thank you. And Lindsay has my slides. I emailed them to her. You all are welcome to use them in any way that serves you. I do this for the work and to really further the work. And so if those things are helpful for you all, you are welcome to them, most sincerely. I have a rule though. I always say the first 2 times you use them, you have to give me credit. But then after you've used them twice, they're now your own. You put some skin in the game, so you own them and you can use them wherever. So first 2 times, give me some credit. After that, it's yours. And no one's counting your 2 times.
Sherita?
Yes.
Hi, it's Audrey. Hi, nice to meet you.
Nice to meet you.
So I just want to tell you that I am a graduate of Beth Israel Hospital in New York City School of Nursing. Retired 4 years ago from lifetime home care. And I did go out and do maternal child health and arranged for home care when mothers needed it. But I have to tell you, hopefully there's been a change since 1969 when I was in the delivery room. And back then, if you had money, you had your private doctor and nobody else could deliver your baby. But if you didn't have money and you were Black, you went through the clinic and you got an intern to deliver your baby. And I can remember a lot of these women not being treated very nice. I had one woman, she was on her 3rd delivery. She was only 2 centimeters. They told me to prep her and she was moaning and groaning. And I said to the doctor, I think she's coming faster. I don't think I should give this. Well, guess what? I delivered her baby in the toilet because doctors wouldn't listen. And hopefully there's been a change for that.
You know, I want to say sometimes, but yeah, I hear far more stories similar to that than others. And I guess one of the things that when I hear stuff like that, it reminds me that, you know, we have lots of work to do, but we as a community are really good about crafting programs that we aim at consumers and at parents. This is an opportunity for us to craft programs that really should be aimed at providers. And what's interesting and a bit of a challenge about that is that providers oftentimes don't listen to people from the community very well. You really need someone who speaks doctor speak, and I'm doing my air quotes, medical jargon, but really has the credibility and the language that doctors hold dearly. One of the things that, you know, I also have learned is that, you know, where we have had issues around like really, really big issues with providers that I tried to work out. We had a group that was really focused on the issue of Black maternal mortality and morbidity. And it was medical providers and community people and social workers all together on a group. And one of the doctors said, you know, I think that one of the things that gets lost is that doctors, when we're really holding fast to things that most people think are crazy, is that we also are focused on the best for that family. And we've got some medical either information or knowledge or experience that makes us hold fast, and we don't want to be sued. We don't want the worst case scenario to happen. Like, no one ever got into the medical profession because they wanted to hurt people. So what it really forced me to do was to really understand that, you know what, if I'm really trying to engage and understand, then I can really have to get a little bit better about listening, so I can tease apart to figure out who needs to be doing the provider education. How do we craft something that is meaningful, and the word that came to mind is sexy, and I don't mean sexy, but I mean meaningful and interesting and appropriate, that medical providers will want it. And when and however we craft that, then how do we then aim it in a way that they can receive it, right? And so that's a lot of work that I still have to do. So Audrey, I might be calling on you, right? Because you've been in the medical experience and you can do those things. And so, you know, like I said, I stay in my lane. I don't know everything, but I'm really good sometimes about making connections. And so, you know, I just really might have to call on you as we really get into my yet to be named committee or coalition or whatever it'll be to really tease it apart.
Do you think that, I hear this from every race, the doctor knows best? Well, did you ask him about that? No, I can't ask him. And do you think a lot of these women who are pregnant and Black women, you know, because the doctors say, oh, well, they're uneducated or stuff. And so they have this stereotype that they've absorbed that, and they will not ask questions. They're afraid of the doctor. They do what they say, and they don't advocate for themselves, where all of us, need to get a little cojones and advocate for ourselves and discuss things more with doctors, nurse practitioners, midwives, whatever.
Yeah, I want to say to you that I think this whole thing about patient-provider relationships and the notion of firing your doctor are relatively new. My grandmother was 89 when she died 2 years ago. And I would because I'm who I am. So I was always talking about babies, and different things. And my grandmother would say, you want to fight for everything. And we just didn't do that. We did what the doctor told us to do. And, we listened to them, and we didn't. And I said, well, Grandma, it's a different time. And you also had friends who died because their doctor wasn't quite paying attention, and they didn't get the right information. And I'll never forget, if you all haven't noticed, I kind of have a big mouth, right? So I had the experience a few years ago. At the time, I was the chair of the African American Health Coalition, which landed me at tables and in places where I otherwise never would have been. And I happened to have been sitting, we were doing a panel to discuss Medicaid redesign back when it was really, really new. And I was sitting between one was a hospital administrator and the other was a doctor. I won't name any of their names. And one of them was talking about childhood obesity. And, he was talking about having better patient-provider relationships and parents listening more and trusting their providers more. And when it was my turn to speak, I sort of naively said to him, childhood obesity is something that's never going to be solved in a doctor's office. You all don't understand some of the causes and drivers. So if I live in a neighborhood on a street where I saw someone get shot, my kid is never, ever going to ride her bike in front of our house. All those things were true in my life at the time. I lived in a neighborhood on a street where I watched someone get shot. And my daughter didn't ride her bike in our neighborhood. She just didn't, but she had a bike. And I would very promptly put her bike in my car. I would drive her 6 blocks over to my mother's house where she rode her bike in front of my mother's house. And then I would put her bike in our car, drive it back to my house, and put it in my apartment, because we lived in an apartment. I wonder now why I just never left the bike at my mother's house, but different issue. But I say that to say that these are the kinds of things that when you think about, providers who will tell parents, well, your child's at the top of the bell curve for weight, after dinner, go for a walk, and never look at their address or never understand what else is at play as to why that child might not be walking or might not be more physically active. I would say a kid at home playing Nintendo between the time that they get out of school before their parents get home, in a parent's mind, is safer than them outside riding their bike. And if that's what my construct is, nothing that you tell me in that doctor's office is going to change that. Because at the end of the day, I want my child to be safe and alive when I arrive home. So the reason that all of these things become important is, remember I was saying about data and information? So if the doctor's looking at the screening test or the scale after he looks and says, oh, your kid's at the top of the bell curve, they really need to be more physically active, and you don't engage me in a conversation around why my child is not physically active in my neighborhood, or what kinds of things might I do with my child to get them to be more physically active, then we've missed the opportunity. And the provider's going to say what he's going to say, and I'm going to go home. And when my kid gets out of school, he or she's going to be right back in front of the TV playing Nintendo until I get home, and we'll go through our routine. So I think that we need to be a little more thoughtful. And some of that is about being sure that our providers are well-trained and are able to, they know how to have those conversations and to look at that sort of data and information and to engage patients in those types of conversations, that our parents are much more vocal about speaking back to doctors and sharing information that allows them to partner with their provider in the health and interest of their child. And we need to be sure that more of those kids who had that experience finish high school and go to medical school to become the doctors that we're talking about. So it's, those are like lots of different efforts and ways that we address that all get to or all come back to the same point. But we need to have, all of those things working together, and that's why this is, such a huge issue that really requires all of us working, because some of you are teachers, some of you are working with high school students, some of you are working with medical students, some of you have friends and family members who are providers, some of you are providers yourself, some of you have access to kids who just, need to have information about what their career possibilities are. So everybody has a lane. And that's why it's so important that, one, I stay in my lane, but that each of us is active in our own lanes.
Jill, do you want to ask your question?
Hi, Sherita. I was just thinking about the point that was brought up about the importance of listening, and that physicians sometimes don't listen. And I just wondered if you knew about the program that's been going on for quite some time, the research at the University of Rochester on mindfulness-based stress reduction for physicians by Dr. Krasner, and I forgot the other doctor's name at the moment. And the reason I bring it up is this has been a research-based program. It's modeled on MBSR through John Kabat-Zinn through stress reduction, but their focus has been about educating doctors one of their focuses, to be better listeners. And I just wondered if there might be a collaboration opportunity, if they're already working to help doctors become better listeners, that there might be an opening to bring together additional training to doctors who are already working towards being better listeners. And so I'll share it with you, in a separate email, but I just wanted to mention it to see if you knew about it. And I always look for creative opportunities to, if something's already going on, maybe we could piggyback on it.
Yeah, so I don't know if he'll remember, I met Dr. Mitch Krasner probably about 8 years ago-ish, maybe. We were using mindfulness practices to reduce stress with pregnant women. And Anita Black, who is one of Ari's coworkers, at one time worked with me, and it was one of the things that she brought to our organization and helped us really integrate mindfulness-based practices with pregnant women as a way to reduce their stress. And so it was something really cool. We also then worked into yoga. So I'm familiar with that work, but not exactly the work, Jill, that you're talking about, and would love to explore that.
Okay, I'll follow up separately.
Thank you.
Yes, sure, thank you.
So does anybody have any more comments or questions? Yeah, Donna.
Thank you, Sherita, for your wonderful, wonderful presentation. I was wondering what we can do. I know you talked about those of us who are teachers, those of us who know physicians, those of us who are in contact with teenagers, but there are a lot of us on this call tonight who are retired. And what can we do to support you in the work that you're doing?
Well, there's a couple of things that you can do, honestly. So I would say that you're part of this group and you all seem to be very active. So you can continue these conversations. You can donate to the Healthy Baby Network, and you could donate either in cause of supporting a family or just to the agency or to the birthing center. You can, when we are able to gather and do events, and we're going to be doing some things virtually for our 25th anniversary, you can become and engage with us in relationship to participate in some of those things, and then share that information and the things that impress upon your heart with your friends and family. And, you know, one thing that I would love for you all to do, and I know that this isn't something that we can come up with tonight, but I would love for you all to pick a project, right? And I don't know what that project would be. And it doesn't even have to be to the Healthy Baby Network, right? So we have some women's shelters. Wilson Commencement Park is a housing unit for single parents. We have Willow, which is a domestic violence shelter. There are all kinds of projects that are really focused on vulnerable families and people. And I would love to see you all. Asbury has a lot of wonderful ones. We talked about RAIN and some of the work that they're doing. And I know that you have someone here who's connected to them, that you all would find something and together do that. So whether it is, you know, and I'm just, you know, thinking out of the box, don't be creative with what you come up with. Adopt, you know, a couple of families and do a meal with them when we can all gather together to sit and talk to them. And when you can, donate to buy them groceries or gather to buy them a washing machine or a dryer or both. You know, something that you all can do together in service of others that is the beginning of extending a relationship that will make their lives better somehow. Like I said, would love to see you get involved with Healthy Baby Network, but there are so many opportunities. And COVID really has presented its own unique set of challenges. So we have, you know, we have more people who are depressed than ever. We have people, we have higher rates of suicide and mental health issues right now. So there are so many needs, but I would love to see you all. My request of you all invited me and now I'm giving you requests. Don't you love it? My request of you all is that you not let this information sit in the presentation on Lindsay's drive, that you pick some things out of it that motivate you all, that you all can do together as a temple in service of. Adopt a smaller church somewhere. Like, there are all kinds of ideas, but something that you all can do together in service of others. And, you know, I'm happy to give you tons of ideas. I'm happy to have another conversation with you later about that. But you know, and once you pick something, if you need some help getting it started, or if you have a little bit of an idea and need the agency that does whatever that thing is, I've been at this for a while. I know lots of people in the community, so I could probably connect you or know someone who knows someone. But pick us something and do something in service of others together. It will build relationship amongst and between you all to another level. It will improve someone else's day in life and circumstance, and you just never know how small something that may seem very, very small and teeny to you all can have lifelong consequences for someone else. It really, really can. Susan, I love how you are smiling right now. You are giving me so much life. And Judy, I just want to hug you because you're giving me this look like this is a big one. How are we going to do this? But I want to let you know that I'm not dropping in to like say this to you all and then go away. My being here tonight is here in service of you all. It's because I made an awesome connection with a lady who reached out because she heard about me from someone else and who saw me somewhere else. And then we just started emailing. And I do this in service of, you know, our parents. We have some really awesome parents that are really leading some really complicated lives. And you all and, you know, your other temples or other places where you're connected to and other people that you know and that you're connected to have the ability to do something really awesome and to do something about that and something that you all can be proud of together and individually, but also collectively. And that's how we make our community better and stronger, when we each are, you know, arm in arm doing, you know, our thing. And so, you know, I'm so appreciative for all the opportunities that I've been granted. And because of that, I do stuff like this. My daughter is milling around the house in the background. She'll never come to the camera, but I would show you all because I just I'm aware that life could have been very, very different for me. Mm-hmm. And when I started at the network 4 years ago, I was a young single mom. For the first year that I worked there, I also kept part of my part-time job at the Y. I was working for the YMCA, and I was working during the day as the front desk supervisor, and at night as I wrote a grant to the United Way for a program called For Young Women Only, which was a mentorship and development program for young women. And so I kept that job and I worked that, you know, that night at nights while I worked full-time for the perinatal network. And I did that one in part because I needed to financially, but two, because I really believed in the work and I knew that these young women would go on to do incredible, incredible things. And, you know, teenagers, you gotta love them. Once you connect with them, if it's in love and they feel loved, you never get rid of them. So I have grown folks now that come up to me, Miss Sherita, and I'm looking at this grown, you know, this 6'2" grown man with little kids in tow going, who is this? But I know it's one of my Y babies. And I still call them my Y babies. And so, you know, and I'm hugging them and I'm telling their, you know, their partners, you know, I'm your mother-in-law, you don't know. I'm telling their babies, I'm your extra grandma. But I do this because I so believe in the work that we're doing. And I believe in each of your abilities and your collective ability to make it better for someone else. And so that's what I would love to see you all do as part of your work, as part of your belief and your faith and your collectiveness. And I want to be here to support you if you need it, or cheer for you if you don't. But that's what I ask of you all in exchange for the time that we've spent together tonight.
Thank you so much. I mean, we're unmuted, so we can really clap.
Oh, thank you, Sherita. Thank you.
Thank you so much.
Thank you. Thank you so much. This was really fabulous.
Yeah, it was.
Well, my prayer is that I wonderfully disrupted each of your lives and that you're leaving a little different than you came. And I'm excited to hear about what you all will do.
I do want to remind everybody that the next speaker is the equally magnificent Melanie Funches.
Woo! Oh, you're in for such a treat. I promise you.
Who will be, I think of her as one of, well, Rochester or Monroe County, or maybe even New York State's greatest mental health advocate. So don't miss Miss Melanie Funches on March 1st. And we are also working on a fourth program that will talk about racism and kids' health and how it, we're looking to tie it into environmental racism and how that affects kids' health. So thank you everyone for
thank you again, Sherita.
For coming, and thank you, Miss Sherita Bullock.
Yes.
Virtual hug, all of you.
Thank you.
Oh, wait, Jill, please put Sherita's email in chat. Yes, I'm gonna put my email in your chat, and I mean it, I promise. It might not be the same day, but I promise you I will get back to you.
Thank you.
And thank you, Sherita, for your call to action. And I just feel compelled to share what I was thinking as you were sharing that and urging us to take even more action. That this work is really about justice, not charity, right? Because it's undoing the systemic and structural racism that has been created and perpetuated over centuries. So anyway, thank you so much for sharing your time and expertise, as always. Thank you.
You are so welcome. You all are so very welcome. Thank you for having me.
Our pleasure. Our pleasure.
Great pleasure.
Bye, everyone.
Bye-bye.
Thank you.
Thank you.
Thank you. Oh. Amazing. Wonderful. Oh.
She's fantastic. No
She
doubt.
is.
Really.
Thank you, Lindsay. Oh my God, I forgot to thank you. I know Sherita thanked you multiple times, but
yeah, she did. Yeah.
Thank you.
Thank you, Lindsay.
Yeah, you didn't have to thank me at all. I'm gonna turn this over to you, Sue, if you guys want to stay on.
Okay.
We can't do it without you.
And can you stop recording?
Yeah.
Thank you, please.